and to occupy the front seats. Those who have not registered, kindly register your names as the certificates will be given accordingly. Nowadays, infertility has become a major concern these days, mainly due to the changing priorities of men and women in the reproductive age, their lifestyle, and also the environmental pollution. As many are unaware of the negative consequences of age on fertility, the delay in pregnancy or postpone fertility treatments. It is estimated that female accounts for 50% of infertility, but now there is rise even in male fertility, which accounts for up to 40 to 50%. In India, the general notion or myth that is infertility clinics are meant only for treating women. The entire male infertility gamut is just ignored. We at Oasis offer all services and treatments for infertility under one roof and have recently started a dedicated arm of male fertility treatments under the brand Andro Life. In our historic journey over the last 14 years, we have become one of the most respected institutions in the country and have helped more than 95,000 couples to achieve their parenthood dream journey. With a class 10,000 environment, our IVF labs are of international standards and have total quality management in place, which optimizes the results of ART. At Oasis, we treat a lot of couples help them to conceive. We earnestly desire to keep you all updated with the latest advancements in the field of reproductive medicine through this CME. At the end of the session, we expect the participants to be empowered with knowledge that will help in improving the patient outcomes. So kindly sit back and relax. Before we start the session, it is customary to light the lamp. May I request today's dignitaries, Dr. Durga ma'am, Dr. Krishna Chaitanya sir, Mr. Kalyanvara, Dr. Venkatramana sir, Dr. Radha Lakshmi madam, Dr. Sri Lakshmi madam to come for the line clamping session.
शुभं कुरु त्वं कल्याणम् आरोग्यं धनसम्पदः शुभं कुरु त्वं कल्याणम् आरोग्यं धनसम्पदः शत्रुबुद्धि विनाशाय दीपज्योतिर्नमोऽस्तु ते दीपज्योतिर्नमोऽस्तु ते दीपज्योतिर्परब्रह्म दीपज्योतिर्जनार्दनः दीपज्योतिर्परब्रह्म दीपज्योतिर्जनार्दनः दीपो हरतु मे पापं सन्ध्यादीपनमोऽस्तु ते शुभं कुरु त्वं कल्याणम् आरोग्यं धनसम्पदः शुभं कुरु त्वं कल्याणम् आरोग्यं धनसम्पदः शुभं कुरु त्वं कल्याणम् आरोग्यं धनसम्पदः शत्रुबुद्धि विनाशाय दीपज्योतिर्नमोऽस्तु ते दीपज्योतिर्नमोऽस्तु ते दीपज्योतिर्परब्रह्म दीपज्योतिर्जनार्दनः दीपज्योतिर्परब्रह्म दीपज्योतिर्जनार्दनः
Morning, everyone. I'm Dr. Divya. On leda. Good morning, everyone. I'm Dr. Divya. Uh, Thank you, one and all. Before we move on to our scientific session, I will request Mr. Kalyan Vara, AVP Strategy, Oasis Fertility, to speak a few words about the Oasis Fertility journey so far. Over to you, Mr. Kalyan.
A very good morning to everyone and a warm welcome from Oasis Fertility. I'm Kalyan. I'm heading the strategy functions of Oasis. So, a quick walkthrough through the growth of Oasis that we have witnessed so far. So, Oasis was incorporated in 2009 by two young entrepreneurs, Dr. Durga Rao and Mr. Kiran. So, Oasis as an organization is an ICMR registered and an ISO certified organization. We are the number one South Indian IVF fertility clinic and number three across India. We are the most trusted experts in fertility treatment space. We have close to 32 centers across India, and right now we are expanding at a rapid pace. So recently we have started our new centers. Like for last year, we have started 4 centers in different geographies in India. To just give you an overview about our founders, we believe at Oasis our core values as collaboration as one of the most core value, and our founders from two different diverse backgrounds have collaborated to start this company called Oasis, where Dr. Durga is from clinical background and Mr. Kiran is from a technical background. So the collaboration has resulted what we see Oasis today. So to give you a brief about our journey, the first phase one, wherein we started our journey in Hyderabad and more or less expanded in Telugu states. In the phase two of our journey, we have moved our presence in other cities and states, and we started spreading our wings in other states. So we moved to Maharashtra, Gujarat, Karnataka, Jharkhand. So we are now at 32 centers pan India. Now the third phase is even more interesting. We are looking at opening our 100th center on 2028. So, but then at the heart of our expansion, we have our clinical excellence at the core, and we have our SOPs to be followed at each of the centers to give the uniformity and the best of the services to our clients. So we have been, accolades and the success are an outcome of our best practices. We have been given acknowledgement about the treatments and the services that we offer at Oasis. We are the fastest growing IVF chain of clinics in India, and these are our accomplishments till date. So why is it we are recognized in the media right now is because of our way of working in Oasis. So we are known for our world class treatments, and then we actually have a very good blend of technology that we use at Oasis along with the clinical excellence. So we have a holistic approach for our patients. We not only the clinical side, we actually have a psychological counseling given to our patients and the diet counselings given to our patients, and there's so many success stories with Oasis. And the core of all this is our fundamental approach of having the patient at the center of all our operations. So we actually give utmost importance to our patients, and then we make sure that the kind of treatment and the kind of experience that they go through at Oasis gives that wow feeling to them. What are our ethos? We are a trusted brand, and we our practices and our treatments are based on evidence, and we actually thrive to give the couple their biological child. This is what we stand for. And coming back to our core values at Oasis, whatever we do at Oasis, it ultimately boils down to these 5 core values. One, compassionate. We actually are very compassionate with all our stakeholders. Two, competent. We have a brilliant team which actually is put together to perform and to deliver the best of the services to our patients. And we actually have customized services to all our clients. It is not a one treatment that we roll out to every other patient, but we customize each and everything based on the needs of the customers. And we are confidential about all our customer information, and the data is encrypted as such. And we are committed to our promises, and we're committed to our practices. So these are the 5 core values that we actually stand for at Oasis. No matter what, we don't differ on moving away from any of our core values. So just to give you a brief again, we have done till date close to about 30,000, more than 30,000 IVF cycles and more than 40,000 IUI cycles. But the most important reward for us is like more than 85,000 families have been really happy with us. And then this is what we take as our reward at Oasis, not anything else. And as we always believe in Oasis, success rate is an outcome of what we do, but the best success rates comes from the best practices that we follow at Oasis. So we are at in total 800 employees in Oasis. That's a huge number, but everyone actually has the same set of value system across their services. We have close to about 120 embryology team, and then we have a support team at corporate more than 100. We are again the number 1 in the center in South India as a leading IVF brand. So we at Oasis make sure, what makes us different, or what makes us different to our competitors. We actually have best quality labs, and then we are NABH certified organizations, and we are a member of ASRM and FOXY. And this actually makes us different to our competitors. Our labs are to the utmost quality. We have a centralized AHU with HEPA filters, which actually maintains our air quality at the labs, IVF labs. We have witnessing systems, which are our IT systems, which are robust systems, which will not give any chance for any sort of error in terms of gamete handling. And our consumables are all toxicity free, tested for toxicity free, and we maintain our clean rooms with class 10,000 environments. As I said earlier, our success rate is something we don't brag about, but then this is an outcome of what we do at Oasis. The best success rates comes from the best practices that we follow at Oasis. Now coming back to the success story of Kurnool, we have done at Kurnool more than 500 cycles, and the success rates have been upwards of 70%. And we have done highest number of PGTs at Kurnool. And the first ever IVM treatment was done at Oasis Kurnool. We have got the first baby in Andhra Pradesh. This is purely under the leadership of Dr. Vijay Lakshmi. How is it we enhance our success rate? These are the advanced technologies that we use at Oasis. One is microfluidics and one is EmbryoGlow. Apart from this, we also have other technology. But then at every process of our patient progress, we actually make sure that we improve the probability of success rates at Oasis. We have, as you have seen, collaboration has been our core value system. We collaborate with our stakeholders, both internal and external. So how do we collaborate? Like at Kurnool in the city, we collaborate with our doctors. Doctors are our representation in Kurnool city. So whenever there's a patient probably with infertility problem, probably the doctors would refer to us, and then we actually treat only for the infertility and send them back for the ANC care to the doctor alone. So this is the kind of relationship that we have built, and this is the kind of model where we want to take along with us, our stakeholders as well, both internal and external. Now, having distributed network of 32 centers across India, how do we operate and how do we make sure that we have uniform treatment and same sort of service excellence at every of our clinics? So the backbone to our clinics is this IT system that we operate, which is called Artis. Artis is the patient management system wherein everything gets recorded, and then we actually use this for our patient management. At every stage of the patient flow, we actually have these triggers and controls at the system, which are useful for our team to actually make sure the patient gets the right kind of treatment and the best of the service. We have integrated, we are in the process of integrating EWS, which is electronic witness system, and on top of it we are working on some AI models which can help in grading the embryos and also help the clinicians and the uh, embryologists in getting the highest probability in our success rates. So AndroLife is another brand that we operate for our male infertility treatments, and we offer a wide variety of services at Oasis. So with AndroLife, we have been helping a couple of cancer patients to preserve the fertility. Another initiation at Oasis is FertiCheck, which is a fertility check at sperm analysis at the doorstep of the patient. So we have this launched in Hyderabad, and we have got a huge response in Hyderabad. So what actually happens here is the patient actually books for a semen analysis, and we have our guide at his doorsteps, and the report is generated within 30 minutes from the sample collection. This is an innovation that we have done at Oasis. Now, another innovation that we have recently done going along with the technology is Ask Oasis, which is a chatbot. So we have collaborated with ChatGPT in getting this chatbot, which is a robotic messaging system where a patient can actually log in. Anybody can log in. The data is based on Oasis 15 years of data. And then whoever has any query about the IVF treatment or any sort of query on fertility or anything to do with the success rates or like whether the treatment is right or wrong can actually go onto this website and then have a chat. The robot which actually takes this, gives the feedback, has the data of Oasis and then actually produces the best of the answers for the queries asked. Probably this would get integrated into our IT systems as we move forward. As a part of our CSR activity, we actually offer free IVF treatments for the economically backward patients. So we get a lot of inputs from our network of doctors and also our internal stakeholders on proposing free IVF for economically backward patients. So we actually go do this to add some value to the society at large. So at core of our excellence, service excellence, we actually have our academic and training, which is the core for all our outcomes. So we have a continuous learning process wherein everyone goes through a limited number of training sessions at our Oshram, which is our training school. So we offer wide variety of courses, both on IVF and IUI, which are long-term and short-term. So we actually offer these courses to enhance the understanding of both gynacs and also other stakeholders in the society. So anybody who finds the course or really interested in getting to this, please let us know. We'll be really able to collaborate with you in setting up your IUI or level 1 clinics, or probably in the standards that we'll have to follow in setting up this level 1 and level 1 clinics. So probably if anybody is interested in collaborating, we would really want to get in touch with you and see how we can take this forward. I would like to request Dr. Vijayalakshmi to take this forward. Thank you.
Thank you, Mr. Kalyan. Now I request Dr. Vijayalakshmi ma'am to hand over a small gift of token to Mr. Kalyan. Photograph. So now we move on to our first session. Now I request the chairpersons for the first session, Dr. Sri Lakshmi Ma'am, HOD and Professor of OBGY at Kurnool Medical College, and Dr. Sriram Prasanna Ma'am, retired HOD RTC Department, to take over the seats. Now I request our chairpersons to introduce our first speaker, Dr. Durgaji Rao Ma'am, who is co-founder and medical director of Oasis Fertility. I request Durga Ma'am to enlighten us with her talk. She is going to talk on defining success in assisted reproduction.
I think we'll go ahead with the talk.
Ma'am.
Good afternoon. I think we really need to thank all of you to take the time out of your personal lives and come and spend a couple of hours with us. And we are hoping to make this as informative and as collaborative as possible. Now, when we are talking about ART particularly, what I would like to sort of get you to understand and appreciate is what exactly do we mean by success in ART. So today, what we would like to take you forward is what do we mean by a success in ART? Now, when we are talking about success in ART, for us, it is not enough just to see a couple of lines on a urine strip. Because this is the first step, I agree, but this is not the last step. The last step is when a woman actually goes home with a baby. That's when you can say that ART has been successful. Just to see two lines is really not the big deal, because the journey from these two lines to going home with the baby is the most crucial and the most important aspects of life. You probably do tend to see this on quite a few websites and advertisements. But unfortunately, fertility hasn't reached that space in which we can guarantee 100% success. And I think society has now come to the stage in which even the patients are appreciative of the fact that the success rates of ART does not cross beyond 40 to 60%. But it has taken years for them to come to realize this. What they think is that once they come to the doctor, we are actually taking their egg and the sperm and doing something in the lab. So why is it that once you put an embryo back, we are not able to conceive? But over the years, I think they have understood that there are lots of other factors that come together to create a pregnancy. But one thing that we have to be aware of and shy away from is this concept of 100% guarantees. In fact, we tell them that unless there is adoption, there are no guarantees in life. Adoption is the only way you'll be able to say that, okay, I can go home with a child. Not even surrogacy, not even donor gametes can actually give you 100% guarantee. So what is it that cause success in ART. There are three aspects to this, and the most important is a healthy mother. That's our first priority. The second comes a single healthy child, and that child not having any kind of congenital anomalies. So for us, success means this: a mother being healthy enough to go home without any kind of complications, and a child also accompanying her who is healthy too. Now, when we are really looking at fertility, when we have a country of this population, why are we still seeing so many fertility clinics? And why are we seeing so many gynecologists interested in fertility? Well, we should be interested in fertility, particularly because when we are talking about Andhra and Telangana together, the fertility rate is actually coming down in this part of the world. What actually, lets a society progress further, economically and otherwise, is when your fertility rate is 2 and above. And currently, our states, the fertility rate is actually at 1.8. And if we are going to continue the way we are going to see a dwindling in terms of not just the whole economic proposition of the state, but even otherwise. So this is where we have to be sure about actually educating our people about the impact that infertility has. Now, what is it that, a patient looks forward to? What makes her go ahead with an infertility treatment? And what for her is not just about, success and having a child, but what are her other implications that make it more attractive to her? These are the three factors. We have to make it economical for her. Now, they obviously feel very scared about medicines. When you're talking about all of these people who come for IVF, most of them actually delay their treatments and they delay the decision. When you ask them why, the first thing they say is, we heard it's very painful. Obviously, they hear that it's expensive, but they also hear that it's very painful and it is going to require a lot of bed rest, it's very intensive and all of that. Now, those are things of the past, but that kind of impact is still carrying on in their minds. And this is where I think a lot of education, right from the grassroots rebels up to the gynecologists and to the fertility specialists, is where we have to take away all of these myths from them. But when we are talking about either a gynecologist to send them to a particular center or for a woman to find which center to go to, what are the things that actually make them have the right decision and take them forward is this. First, ensure that the center that you're sending them to actually has a skilled and an experienced clinician. We were just having a chat with one of our senior gynecologists just now, that centers are opening in which the actual main clinician is not there, but is being handled by other junior gynecologists. Now, when you do not have somebody with an experience and the skill and the knowledge, that happens, what is the outcome that you're actually giving the patient here? It is not just about the clinician. Now, when we are talking about fertility, we are talking away from being a single person's impact. A gynecologist can practice singly. An obstetrician can practice singly, but not a fertility specialist. For a fertility specialist to be actually effective, it is a teamwork. It is not just about their knowledge and skill, it is about the team in terms of an embryologist who also has to have the right kind of skill and experience to give them the outcomes that they deserve. And on top of all of this is to ensure that your SOPs and your total quality management system is in place. And this is where I think these three factors are where we are very, very concentrated upon. And this is what gives us the success rates. And we always ensure that our SOPs keep getting updated because this is a very young field. There's a lot of research going on. There are newer things that are coming up every few years. And how are we adapting to it? All in a way that we can give the best outcomes to the patients is what keeps us ahead. And the most important thing is to avoid any kind of complications. Now, when a patient walks into a fertility clinic, she is healthy. They can come to an obstetrician or a gynecologist or any specialist with some certain kinds of problems. But when they're coming to us, they're actually healthy. We need to send them home healthy as well. So what are the complications that ART can do? One is OHSS, and the second is multiple pregnancy. And for us, multiple pregnancy is a failure. Like I said, what is it that a fertility specialist goal is? A single, a healthy mother and a single child. Twins does come with its complications. And for us at fertility, we have to avoid any kind of complications like that. Now, when we are talking about treatments as well, the initial steps are the most important for us. How do we evaluate them? How do we plan their management? For us, age of the woman is the most important aspect. Whenever we are talking about initiating any management plan for them, we don't talk of AFC, we don't talk of AMH first. We talk about their age first. Age, BMI, then comes your ovarian reserve factors in terms of their AFCs and their AMH, and obviously in association with the male factor. And it is in this order of preference that you should initiate any kind of management plan for the couple in front of you. When we are talking about ovarian reserve tests, the most important aspect, and for us the most reliable, is an antral follicle count. We really don't look at an AMH to plan a patient's treatments. We look at the scan that is being done by us, because here our evaluation in terms of an ovarian volume, the number of follicles that it has, the accessibility of the ovary, the blood supply, the uterus, any pathologies in the uterus is what enables us to actually manage and effectively plan the treatment. AMH is a piece of report for us that we use for counseling the patients in terms of telling them the fertility journey. AMH is not something that we utilize for their treatments. But this is an important piece of paper for us to help counsel the patients, for them to understand what their fertility journey is. Now, AFC is something that as gynecologists and as specialists we see, but that is not something that they appreciate. But an AMH piece of paper going to any gynecologist in the city will come with the same report and the same kind of advice. So that is the importance, but not in terms of their scientific outcomes. Now, how is AMH really going to help us? It helps us in saying that the higher AMH actually gives you better number of oocytes. But number is not the only factor that helps us in winning the game. What actually is important is the quality of the oocytes. And this is where age actually helps us in terms of giving them a better outcome. You might have a 28-year-old woman with an AMH of 0.9, and you'll have a 36-year-old woman with an AMH of 0.9. Are they going to behave the same? Even if they have the same AFC? The actual answer is no, because age here has more impact than that AMH. So yes, numbers are important, but what is probably more important is also the quality of the oocytes that we are going to be giving. Now, the lower the FSH also, the better the outcomes are. And better than AMH in terms of enhance, or rather giving us a depiction of the quality, FSH might play a small role. Now, when we are talking about age, does that mean that as we are growing older, our chances are reducing? Yes, they are. But what is the reason for that reduction? Is it only because of the numbers coming down? No. It is because of the aneuploidy. It is because of the genetic competence of that oocyte that actually reduces your chances too. And how is that actually manifested? This graph actually tells you, what does it tell you? The actual line is straight, which means that whether you're less than 35 or you're more than 42, why is it showing that your take-home baby rate or your cumulative live birth is the same? This is not what we tell patients. What this line is actually telling you is that even if you have a woman who's more than 42, but you put a euploid embryo, an embryo that has been genetically tested and transferred, their chances of success is as good as a woman who's less than 35. So the impact of age is not just on the numbers, it is on the genetic competence. And if you're able to transfer a genetically competent euploid embryo in an older woman, she still has the same success as a younger woman. Now, one thing which we are learning over the years is that it is not just about the woman's age that makes an impact, it's also the father's age. And in fact, the impact that a paternal age has on the progeny is there's a higher risk of schizophrenia, there's a higher risk of autism and other abnormalities. So when we are talking about, getting the couple to take the right decision at the right time, we have to take not just the woman's age into consideration, but we slowly need to start adapting to the fact that even a father's age is important in terms of the outcomes for the child. Now, implantation rates, how is it that we need to improve? How do we make our ART cycle more successful? Obviously, this is where embryo culture, and this is the reason why we put so much emphasis on in terms of the quality of the lab. What are the SOPs that are being followed? How are we maintaining the quality of the lab? Just having a fancy lab is not enough. We really need to ensure that the quality continues to remain the same. Your air quality remains the same. Your particle counts are low. So how do we do that? You improve your embryo culture. For us at Oasis, 99% of our transfers are blastocyst. Why? Because blastocyst gives you a better implantation in a day 3. Yes, it does come with a small risk that a patient might not have an embryo transfer if all the embryos do not, if some of the embryos do not become blastocyst. But rather than giving them a failed test at the end of a whole month, a blastocyst would actually give them a better chance of an implantation and also give us that knowledge as to what the quality of the gametes are. We do all our embryo transfers under ultrasound guidance, so then we know exactly where we are placing the embryo, which gives us the best implantation. And like I said, we do a lot of pre-genetic testing of embryos so that we can increase our chances and the woman goes home with a healthy baby, like how I showed you about the chances. Now, another aspect is what are the chances of success when we are talking about ART? What are the figures that you tend to hear? If you're going to transfer blastocysts which are not tested, your success rate is only somewhere between 40 to 45%. But what happens when you're transferring a genetically competent embryo? Now, this figure actually tells you in 3 attempts, and with each attempt, if you are transferring one genetically euploid embryo, you'll only have 10 to 12% at the end of 3 transfers who are left without a pregnancy. Which means that more than 80%, if they have 3 euploid embryos, can actually go home with a baby. And it's only between 10 to 12% who will end up having recurrent implantation failures. But obviously, this means that that couple has 3 euploid embryos. And not everybody will reach that stage to have 3 euploid embryos. But should they get to that point, 80%, more than 80% will go home with a child. And we are not just talking about 2 lines, I'm talking about them going home, take home baby rate of 80%. Now, this is the study which actually gives you that impact. But what is also very important for us to understand is that more than half of them who don't conceive actually drop out. Now, this is where we have to educate our patients about the success of what I have shown you before. That if they persist in treatments, their success rates are much higher. It is because they actually drop out of treatments that you tend to have more failures. So persistence is more important for them. And if they go for at least 3 embryo transfers, like we said, more than 80% are likely to go home. Now, what about in this age of ART? What is the stance of tubal surgery? Well, tubal surgery still has a place. And tubal surgery in this day and age, when we are getting better in terms of laparoscopy, when we are getting in terms of our suturing technique, doing a tubal reanastomosis for people who have had some kind of either pathology or they have had, tubectomies, it is still something that we can consider. But what are the indications for us? When should we really consider tubal surgery for them? You should only consider tubal surgery for them if there is no male factor. If the woman is young, she's got a good ovarian reserve, there's a possibility for her to conceive if her tubes are recanalized. And if she's looking for more than one child, then the expense of the laparoscopic surgery does make sense because she is looking at more than one child. So you have to look at the whole picture. You have to look at the condition of the mother and the skill of the laparoscopic surgeon and how the tubes have been disconnected. Was it diathermy, in which your chances of recanalization are much lower, but if it's a clip, your chances of recanalizations are much better. So ultimately, what is it that we are looking at in terms of goal of ART? Our goal as a specialist is to increase your implantation rate and obviously to reduce miscarriages. So what is it that we are doing to cater to these two factors? How do I increase implantation rate? Like I said, blastocyst transfer. I will treat any kind of pathology like endometriosis, fibroids, PCO, hormonal imbalance, androgens, and then go for a transfer, which increases the chances of implantation. How do I reduce miscarriages? I will evaluate the male factor. I will ensure that the sperm that we are picking up to create the embryo has the least amount of DNA fragmentation. Second, by doing genetic screening of the embryo, I'm reducing miscarriages. Anybody, whether they try naturally or with ART, there's at least a 25 to a 30% chance that a woman might undergo miscarriage. But if I put a euploid embryo, your chance of miscarriage comes down to less than 10%. Third most important aspect is give them the right kind of hormonal milieu, improve their progesterone supplementation in such a way that the implantation is ongoing and they carry on forward. We also want to reduce antenatal complications. Like I said, it is not just my job to get her pregnant and then send her over to you and expect you to take care of all the complications. I have to give you a patient who is not going to trouble you during her 9th month of antenatal period. How do I do that? And what are the most common antenatal complications? Diabetes, hypertension, second trimester losses, preterm labor, and any kind of placental complications. For us, as fertility specialists, what is it that we are going to be doing? We will take the precautions in terms of looking at the cervical length. Do they need any kind of treatments for that? Do they need a stitch before they even do an embryo transfer? Do I rule out thrombophilia so that I can avoid a second trimester loss? I don't want twins because they cause problems. I'll do a single euploid embryo transfer. And if I do an embryo transfer in the natural cycle, I'm actually reducing all the hypertensive complications in pregnancy. Preeclampsia is less, antepartum hemorrhage is less, IUGR is less. So how I actually prepare the woman for the pregnancy is also important so that you don't have to end up treating all these complications in that woman. So this is where, like I said, infertility is teamwork. We are looking at fertility specialist and reproductive endocrinologist, and both of them together is what would help us in terms of achieving what we are looking at. And like I said, infertility, before they get to that reproductive age, there is a lot that happens in their young adult and adolescent, which can actually impact their fertility. So even before they come to a fertility specialist, there's a lot that we can do as gynecologists in society to ensure that we are reducing the This is a huge concept now for us as fertility specialists. Like I said, we don't want to get to the point wherein we are suggesting to the couple, go for donor eggs or donor sperm. What has our goal always been? To give them their own genetic child. Anybody can do donor gametes. What the couple is actually looking forward to is having their own genetic child. of fertility preservation, at least in most of the, South Asians, we as Indians, we see a lot of fibroids in our women. We see a lot of endometriosis. We see a lot of PCO. And all of this has impact in terms of their fertility journey. What is it that we can do? Fertility preservation, not just for malignancy, but even for endometriosis. So we tell young girls that, if you're seeing, or the gynecologists, we tell the people who are treating the young girls, if you see severe endometriosis, if you see bilateral disease, please speak to them about fertility preservation and then put them on suppression with either the pill or Dynogest. Turner syndrome, these are the group of people who actually go into premature ovarian insufficiency. So if you see the features, get them to freeze their oocytes so that even if they go towards premature ovarian insufficiency later on in life, they have their frozen eggs to carry forward. Now, another aspect which is really troubling us nowadays is the cesarean scar niche. Most of our deliveries are cesareans. We all acknowledge that for various reasons. I'm not going to be looking at the policies for that. But what we are seeing is that the increase of secondary infertility nowadays is actually catching up with primary infertility. You would expect that somebody who's had a natural conception before should not have a difficulty having the second child. But we do tend to see that. And most often in women who have had a previous cesarean section. Now, healing of each one is different. We are not saying that the technique of cesarean section is a problem, but the way sometimes the tissues heal can be a problem. And we tend to see all of these women having fluid collection in the lower segment that actually help in terms of reducing their implantations whenever they go for any kind of treatment or even on a natural pregnancy. And that is what is something that we need to ensure when we are doing a cesarean section, to ensure that we are giving them a very good scar which has the best chance of healing. Now, advancements in cancer treatments, like we said, with all the chemotherapy, nowadays we are even looking at immunotherapy, personalized medicine for cancer. All of this is actually increasing the survival rate. In fact, just a few days ago, there was this International Childhood Day in which we were called for a talk. And you will not believe the kind, the number of people, childhood cancer patients who are surviving, 20, 25 years post their cancer treatments because of the way the skill has improved. And now post their treatments, they're at their stage wherein they're looking to, start their family. And because fertility preservation was not spoken or was not given as an option, are now looking at only donor gametes or even surrogacy as an option. At this day and age, for us not to have considered fertility preservation for this group of people is actually a medical negligence more than anything else. And most of the women, if you're really looking at it, 45 to 50% of women who have cancers have breast or cervical cancers. And the treatments for these do have an impact on infertility. So it's all the more important for us to take care of these women. Now, going forward, even now, a lot of oocyte vitrification is what is being done for them, even if they're not married. Even if they are in their late teens, we still go ahead, freeze their eggs, and then they commence with their treatments. And after, a few years and remission of 2 to 5 years, they come back to utilize their gametes. There's also the option of vitrifying the ovarian tissue if we do not have time for the stimulation that is required to extract eggs. Now, personalized fertility treatments. I think personalized treatments is the way forward, not just for fertility, but in all cases. When we are talking about oncology, when we are talking about rheumatoid arthritis, everything, it's what fits the patient. It is not what is there for everybody else. For this particular couple in front of you, we have to see what is the best design for her. And it's very important that we have a holistic approach in terms of diet counseling, see whether we can actually give them some kind of financial aid so that, like I said, we can reduce the dropouts, psychological counseling, obviously, and ensure that they are fit not just for the treatment, but for the rest of the pregnancy as well. And as much as possible, our goal is to give the woman and get them to be pregnant with their own gametes. At Oasis, donor gametes usage is less than 15%. 85% of our patients, we try and do the best in terms of getting them pregnant with their own. So our goal as such is to make it accessible, is to make it economical, is to make it safer, no twins, no OHSS, individualize and give them the latest treatment options, ensure that we are giving them the best success rate in terms of all the options that we spoke about, blastocyst transfers and euploid transfers. And there's a lot that is going on in terms of research at Oasis, and obviously because of all the team that we have, and a great focus in terms of teaching and training, not just for our doctors, but also for the gynecologists out there. So what are we looking at in terms of future? We are looking at hormonal preservation. I'm not just talking about gamete preservation. I'm talking about hormonal preservation. What do I mean by hormonal preservation? Even if a couple, have finished their family, but if either let it be cancer or let it be premature ovarian insufficiency, rather than them taking HRT, if we can vitrify the tissue and re-implant them, once they go into premature ovarian insufficiency, then you don't need to give them HRT. That tissue is going to give them the hormones for the next at least 5 to 7 years. So you're reducing their complications in the future as well. So we are looking at hormonal preservation, not just gamete preservation. We are hoping to see a lot of genetic engineering wherein the embryos which have any kind of genetic problem, which are right now being wasted or discarded, can actually have some kind of genetic splicing being done so that we can reutilize those embryos and they don't get discarded. Uterine transplantation, yes, a few years ago there was a huge hype and we felt that that could be an answer. We are still hoping to see much more inroads into that, and hopefully in the future stem cell therapy and hopefully in people who go into premature ovarian insufficiency, see whether we can actually activate and make them produce their own oocytes. So even if a woman is older or goes into premature ovarian insufficiency, doesn't have to go towards donor gametes. So these are the aspects that fertility space is looking forward to in the future. Thank you very much.
Hello.
Age of the female partner is especially South Indian population. When we compare the Western setup, the oocyte quality will come down as the age of the female partner decreases. That's one.
Yes.
And also it has stress more important on the BMI, which is also more important. And not only the female partner, and you're stressing on this male partner age is also very much for your informative lecture. We are very thankful to you. And one more thing which I want to clarify is, you said when you transplant a euploid embryo, the success of ART is going to be similar in the age groups, the younger age or the older age.
Absolutely.
But the endometrial receptivity may change as the age advances. That's the one which I
Not
want
really,
to clarify.
because see, even when you have, that is the reason why the age at which ART can be offered to a woman is up till 45 to 50, which means that the receptivity of uterus is still okay. Where the problem comes is in the quality of the embryo that is being transferred.
Yeah. So, okay, then thank you very much, ma'am.
Hello. Well, at the outset, let me congratulate Dr. Durga Rao and Dr. Vijayalakshmi for their excellent service, and the Oasis team also for their excellent service to the humanity. And actually, right now our India is young India. But previously in the past, the government used to stress on family planning. And so there were iddaru muddu anevallu. Later it became okare muddu, iddaru voddu, okaru muddu. Now, even without children also people are surviving. So what happens in future, our economy and our younger generation also will come down. And so for that purpose, you people are doing excellent service. Thank you very much, madam. Thank you.
Ma'am. Thanks. Vote of thanks to Dr. Durga, ma'am. I'll explain. Thank you, Durga ma'am. Thank you, Sri Lakshmi ma'am and Prasanna ma'am. Now we move on to our second session. Now I request the chairpersons for the second session, Dr. Venkatramana sir, who is the president of Foxy, Kurnool, and professor at Vishwabharati Medical College.
tests which do help us in optimizing the success in ART. So coming back, how do we go about managing the male in our OPs? And it gives us the best advantage because both the couple are there in front of us. and you know what's happening with the female partner, and it gets easier to convince, counsel, and offer the treatment. So that's probably the most important slide of my lecture. Whenever we have a male partner who's wanting some kind of help, I think these are the 5 important points under which we get information, and it just makes it easy to handle and manage the male partner over there. So it's always a good thing to take a history and examination. I think what we've always done is the female partner comes, and what we do is we just say, why don't your husband get a semen analysis report? A prescription is given to the wife. Now, and then a report comes to you, and we just want to look at the inference and decide whether it's still a OITA cycle, IU or IVF. I think they should come as a couple. Before even we order for a basic semen analysis, I think a detailed history and an examination really helps us understand the situation, needs, what is the timelines, can we wait or not wait, and how do we go about it? Because at times, a young couple, let's say, 23, 24, married just for 6 months, their needs and timelines versus somebody who's married for 10 years, I'm sure our approaches are different. And this is where a detailed history and examination really changes the way we are going to handle the patient. Investigation, semen analysis is not the only investigation, but your semen analysis, the way you interpret the report, I'm sure it guides you what next investigations to do, and also avoids us from doing unnecessary, unwanted investigations. We do not want to have a huge list of investigations where we get every man coming in getting those investigations. I don't think that is absolutely not welcome in the era of Google, where patients are smart. We are going to be trolled for just writing unnecessary investigations. Utilizing it in the management of the patient. Is there a need for medical management? Is there a need for surgical management? Those are the questions we are asking ourselves. And if the answer is yes, and you're going to do something there, I'm sure the management is getting easier. What is the choice of ARTs should always be the last thing that we would want to know. So a detailed history and examination, you really know what this journey is going to be like. You then, apart from analysis, you want to see what additional investigations. Then, in terms of medical management, apart from antioxidants, is there a role for HRT or anything else that you would want to do? Surgeries are very simple. In terms of male infertility, there are only 2 surgeries. Do you want to get the varicocelectomy done, or is there a need for some kind of surgical retrieval of sperm? Then comes your ART, whether you want to do a OITI, IUI, or IVF-ICSI. A, B, C. There's no option D here. And if with every patient walking into your OPD, if you can get the information into these 5 subtopics, I'm sure handling a male fertility in a gynec OPD is not rocket science. Few important points on the history. I'll not really brag much, but the age of the male partner is important. It's just women don't age, men also age. We thought is at 50 years, but there are recent reports we're saying after the age of 40, given the current lifestyle challenges that everybody is going through after the age of 40, there is a lot of changes that the body is undergoing, and there can be fertility problems. It's not about a man the sperm not letting the lady conceive. It's more about an aging man. The problem is it's the health of the child. There are several reports which says that which an aged man, let's say with so much of reproductive tourism, I see a lot of African patients coming for 50, 55, 60 at times for getting assisted reproduction in India. The problem with such fathers is the children are going to be at an increased risk of neurobehavioral disorders. So the age of man is important. We just can't say man is fertile throughout his journey. That's a myth, and that's what the literature at this point says. How long have they been married and how long they've been trying? That really helps us make a lot of decisions. Did they have any previous treatments? Because if somebody has had an IO or IVF in the past and they've come to you We can't again say I'll restart the journey from an OITI cycle and the next 2 to 3 years I'm going to repeat everything. It's so very important to understand what was done in the past and how are we going to add on and take the journey subsequently. It's important. There are certain occupational hazards. Even doctors, to that matter, these days have a lot of occupation related issues, and we do see doctors coming with a lot of incidents of infertility. I've seen yoga teachers coming with azoospermia or severe male factor infertility. So I think it's important to look into their lifestyle, the amount of stress, the addictions these people have, their body weight, and then go ahead with that. What kind of medicines these days people are on? I think after the age of 25, 30, we see diabetes setting in, hypertension setting in, and they do affect the testicular function. Any surgeries that could have affected the testicular function. Sexual history, I'm sure than the patient, we are more a little shy. There's a lot of taboo to talk in depth about the man's or the couple's sexual life. We're dealing with reproduction, and if they're not having regular penetrative sexual intercourse, which in the current day, with so much of IT jobs and multinational jobs coming in, where everybody is working at a different time zone, I think time for personal life has become very, very little. I think sexual intercourse is a Saturday night affair. There were days where people went out for pub Saturday night. Now it is time for sexual intercourse. Well, there's no way this lady can fall pregnant if she's having intercourse 4 times in a week. I think 3 attempts, at least every alternate day of regular penetrative sexual intercourse, is what is increasing her probability of her she falling pregnant. So in-depth information about sexual history is very important. At times we just ask the lady, is everything okay? She says everything okay. We need to ask leading questions. When we were taught history taking in our second year MBBS, we were told not to ask leading questions in history taking. But this is one segment, sexual history, where probably we should ask leading questions. Otherwise, the issues are not going to really come to the light. A lot of focus on lifestyle. I think managing the lifestyle is probably the first thing. So our prescriptions have 2 important things than writing an antioxidant, folic acid, or any other thing. Regular sexual intercourse, lose weight, stop smoking, bring down your binge alcohol intake, adequate sleep. I think these probably are the first things that need to be counseled to every man who's coming for a fertility intervention, and then look at the investigations and then go ahead. There are not 20 investigations that we do apart from semen analysis. Those are the only things, and I'll tell you how to use these in interpreting it. So what are the important points to consider when a man comes to you for management? Is, never start any treatment to the female partner without the man having a basic semen analysis. No folic acid also would be given. They have to come as a couple. Woman comes on the day 2. You all know, you're the experts what to do. Man without a basic semen analysis done, we're not doing anything at the female side. Because even today, we see women undergoing 10 induction cycles and then a semen analysis where there's a lot of shock and surprise, where the man is either having severe oligoasthenoteratosis or azoospermia. The next most important thing, whichever lab you're sending your semen for analysis, is it standardized enough? The first and the foremost important step is your semen analysis. And if this goes wrong, the entire journey is going wrong. So please ensure that the lab giving reports is standardized. They've put in enough amount of focus into training and standardizing the way semen analysis is done. Even till today, we do see a lot of reports coming from the general pathology labs where the reference value for the count is 50 to 150 million, 60 to 120 million, or 20 million, where the recent WHO has taken 16 million as the normal count. And that is why just going to the inference of seeing a report as oligospermia is probably not right. You got to read in between the lines, see if the reference is right, and if the report is not done properly, I think we need to get it done in a center where it is correctly done. Then only I think the management gets better. every 3 months, because the spermatogenic cycle is around 60 to 70 days, every third month you have to repeat their semen analysis. If somebody has come down with a semen analysis report which is probably an year old and wants me to treat them, I think it's not a fair thing to do. I think you need to keep repeating analysis until they finish their thing of, they being pregnant and having a live birth. And it's all about how you interpret the semen analysis. Few little prerequisites. Why just writing in your prescription to the female partner, go get your husband to get a semen analysis done? The reason is, there are certain prerequisites, certain instructions which we have to make it very clear. One, I think it's best practice to get viral markers done for everybody. A hugely critiqued SOP in most of the centers, they say, analysis is 200 or 500 rupees. Getting a viral screening is sometimes 1200 or 1700 based on the lab where we are sending. Isn't that making it too expensive? But you know what? We all are at a higher risk of catching up some viral infection. So without HIV, Hep B, Hep C, I don't really think a semen analysis should be done. The healthcare workers should be given this support from our end, and only we can make the change. We do not touch any semen sample without viral screening being done, and that's a very, very strictly followed SOP at Oasis. Trust me, every month we pick one hepatitis B positive. Every month in every center, there's at least one which we have picked up where the patient is not aware. With so much of awareness of retroviral infection and the therapy, I think very less first-timer retroviral positive people are picked up, or HCV, which is very rare, but a lot of Hep B is prevalent in our society. And I think this is one of the way to screen and pick them and help them and guide them, because all these, be it retroviral, Hep B, Hep C, they can conceive. The chance of vertical transmission or seroconversion of the female partner with the existing technology is absolutely minimal, very safe, and we'll see how that happens. If there's collection difficulty, please let's address it. So just asking a man to go collect a semen sample without these instructions, what is the abstinence, prerequisites, sometimes the report what we're getting is not right, and the man doesn't know what he should be doing. Do not be surprised, even in 2024, where Google is so easily accessible, there are men who do not masturbate. There are times where they do not know how to collect a semen sample. A simple thing, when we say abstinence of 2 to 7 days, for them abstinence is sexual penetrative intercourse abstinence. They do not consider a nightfall or masturbation as a mode of ejaculation. It might sound very, very simple at times, common sense, but I think you've got to elaborate on certain things. That is why if you do not have a time, have a printed format. Get your counselor or a junior doctor to explain, because semen analysis is the most important gold standard. Spend a lot of time on that. Your FSH, LH, testosterone, ultrasound, they probably just give you one value. But semen analysis is making or breaking the journey, and that's why I'm spending so much of time on that. So please be aware, the recent WHO 6th edition is now into practice, which is 2021. And if we still are not taking 16 million per ml as the cutoff for count, which is anything less than that is oligozoospermia, progressive motility of 30% and a morphology of 4%. Anything less than that is where there is an issue, and we need to be dealing with that. If you do not have these references in your report, it's time to speak to the pathologist in the lab there, and please let's all bring across some uniformity into the practice. Interpreting of semen analysis. Oligozoospermia, let somebody coming with 5 million sperm count. You know what? There's no guesswork here. You send it to a urologist, or I do it. The probability of the treatment is ICSI for them, most of them. 5 million sperm count, what are we going to do? No, there is no guesswork here. But why should you interpret? Because there could be something in the way the semen was collected or the report was done, which is making it suspicious, where you might want to get a repeat semen analysis. Like if the count is low, probably the person has spilled the sample, the lab person didn't ask for it, you didn't ask for it, but there's a spillage of the initial part of collection. And that is what is coming up as oligozoospermia. So a repeat thing is probably going to help you. A very shorter abstinence, probably he's had intercourse at 4 a.m. this morning, and he's come for a test at 10 a.m. this morning. The count probably is less because the volume is less, or there's a collection difficulty. The premises where he has gone for semen collection was a stinking washroom. And how do you expect a man to get aroused? It's physiology. Arousal is needed for a man. Until the brain is stimulating the hormones, blood system, nervous system, a complete arousal, a complete erection has happened, ejaculation is not happening. So sending a man into a washroom or sending him to a place where he's very uncomfortable, I'm sure the ejaculation is not happening the right way. And I think we got to be taking these into consideration. Or if your reference range is not good, then the test itself is not done in the right place. I think the next time we see a oligoasnotereto, let's go in between the reports to see whether something non-pathological that has led to this inference, and let's look at reforming or changing and fine-tuning this. Similarly, for motility, asthenozoospermia, did the man use a lubricant? Let's not assume that the man will just go masturbate and he knows all about it. I've had men using condoms to collect a semen sample. Condom has a lubricant, and that's spermicidal, and that per se is going to get your motility down, or a very long abstinence. Nobody told him abstinence was important. It was a 30 days abstinence. The motility is expected to be low. I've seen men, after spilling the sample onto the bed, scraping it back into the semen container and giving it to us. The motility is going to come down. That's why asking all of these is important. The last thing, delay in assessment. How many reports that you see mention the time of collection, time of evaluation? A very, very important aspect. Leave a general pathology laboratory, even in a fertility center. This can happen where the man has given the sample at 9 o'clock, but for whatever reason, it's assessed only at 12 or 1 in the afternoon. As per the WHO manual, the first 30 minutes is where the assessment should happen, because after that, the pH of the seminal plasma is changing. So if the time of collection and evaluation is not in the report, then again, we really don't know if this is the reason for which the motility really went down. Home collection is allowed, but again, if the person has collected at 6 a.m. in the morning and brought it to 10 a.m. into the lab, or it was not stored or brought to the sample in the right way, the motility can come down. Finally, it's the viscosity. If your sample is highly viscous, then there's so much of mucus strands that will not let the lab person assess the motility. It's not liquefied, so you're not getting the right picture of motility there. So if it is a highly viscous sample, I will not go further down in the report at all. First, treat the viscosity. It could be infection, it could be something else. But treat that unless the sample is liquefied in the right duration. If you're looking at a motility which is only 10%, 90% immotile, and I see highly viscous sample, I cannot say go for ICSI because you have a severe asthenozoospermia in the sample. It gets very difficult to do that. Case of persistent low volume ejaculate. How many of us have really looked at this? 1.5 ml is the accepted volume, or as per the WHO manual. But if you have a persistently low volume ejaculate, if there's 0.2, 0.5 ml, a natural conception is not possible in these people. So it's important we address this, and it can be done at our end. Sometimes it's the spillage or the shorter abstinence which has caused the low volume ejaculate. But if it's persistent, the problem first is that it's your seminal vesicle level, because the majority of the seminal plasma is coming from the seminal vesicle. So there's a problem with that. There's either agenesis or absence, or there's testosterone deficiency. So this is where a truss or a hormonal management, somebody with a very low testosterone will have a less libido, less arousal, and that is why there's a low volume ejaculate. And the last thing is retrograde ejaculation. So somebody with persistent low volume ejaculate, if you've ruled out spillage and abstinence timing, then we're looking at the seminal vesicle, you're looking at retrograde ejaculation, serum testosterone. All of this can be done in a gynae OPDs. Do we really have to refer the patient to another institute where a urologist has to get involved? I think we can deal it at our ends. Chronic infection. On a wet preparation, if somebody is saying 15 per cells, we all have a tendency to give them antibiotic. I don't think that's the right thing to do, because there are a lot of other round cells in your seminal plasma which can look as like a WBC. Unless I have done a staining method, there's no way I can prove it. Now, how many labs offer staining because it's not a Leishman stain. What you really need is a peroxidase test to look at the WBCs. So at least get a semen culture sensitivity. If there's growth, treat it. So that's probably the way you're going to deal with it. And why are we worried about a chronic genital tract infection? Because it can fragment the DNA of the sperm. Normal count motility, but the DNA being fragmented, that could be detrimental for the pregnancy outcome. A highly viscous sample, again, infection probably could be in the prostate. That's the commonest thing. Putting the sample at 37 degrees could help liquefaction because the enzymes can activate at that temperature, or a mechanical pipetting. In clinical practice, one little thing that we do at Oasis, if there's persistent viscous sample, we give a mucolytic. Guafenicin is available as an oral tablet. I'm sure you all have used it for cervical mucus thinning as well. So guafenicin, 200 milligrams, 1 BD, probably a week from the expected time of ovulation, sometimes does help in semen liquefaction. That's how you probably would want to deal with a highly viscous sample. Oligozoospermia. I think this is the commonest report that we're seeing in our practices apart from azoospermia. So if you have oligozoospermia in history, I think those are the important points. I'm looking at occupational hazards, any medicines or surgeries or lifestyle which has caused this. In terms of investigations, when you've interpreted the semen analysis report, if there are 2 reports which are less than 10 millions, then get the reproductive hormones. It's just not FSH. It's FSH, LH, testosterone, and estradiol. These are the bare minimum things. What we also do at Oasis is TSH, prolactin, and a HbA1c. Again, in every 10 men where I get this hormonal profile, I pick 1 HbA1c that's raised. I'm not exaggerating. In every 10 men, we're picking 1 HbA1c that's deranged. I'm not the concern to treat, but at least if this is what is causing some issue, I think within time I can alert them and do that. In terms of medical management, well, we'll talk a bit more of when to give hormonal treatments, which is letrozole, clomiphene, HCG in subsequent slides. Is there a role for surgical management, which is a varicocele repair or a TISA? Again, unless it's justified, unnecessarily putting them through a surgical management is not going to help. IUI, IVF, ICSI, again, there's a table I'll show you how to guide. Motility issues. I think count, at least to an extent, can be boosted with some kind of medical therapies or surgical intervention, but can I really improve the motility? Apart from frequent daily ejaculation, lifestyle management, I don't think there's magical medicines. Antioxidants have been used because the primary reason for motility to come down is oxidative stress, so put them on antioxidants. But apart from that, there's not much in terms of therapy that can be done, and those are the investigations and the way I might want to handle the person here. Necrozoospermia. There was a point where we thought 100% immotile cells was necrozoospermia. The newer definition is if you have vitality, that is alive cells less than 54%, that's the newer definition of necrozoospermia. So if somebody has got very few alive cells and more dead cells, the answer is ICSI, but can you do something? Yes, there's, again, in terms of medical management, it's antioxidants, daily ejaculation, and antibiotics, if there's culture positive. If at all you have this absolute necrozoospermia where everything is immotile, there are times where people have said go for donor sperm. I think the current literature says do a TISA for them. TISA is for azoospermic individuals. We all know that in MBBS itself. But now there's newer indication for doing TISA. One is if there's complete immotile cells, or there's raised DNA fragmentation, or even people with very low counts, they say do a testicular sperm aspiration, use testicular sperms to do ICSIs, and that can give you a better success rates. So testicular sperm gives you a poor outcome is a myth. Whether it's ejaculated sperm or testicular sperm, now with the advent of ICSI and modified culture techniques in the laboratory, the outcomes are all the same. So it's time to think out of the box now. I think this is the commonest thing everywhere. They don't know what to tell. It's like get rid of the patient here, circle that teratozoospermia, you have only 2% normal forms, and that is why you're not falling pregnant. go to a fertility center and get a ICSI done. Isolated teratozoospermia, normal count, normal motility, the weightage on morphology is not much. I'm not meaning to say that morphology is not important, but only a morphological low value is no indication for IVF. Let us not counsel our patients to go for IVF telling them that your morphology is low. First of all, we don't know what is the reason why people are having teratozoospermia. It is assumed to be oxidative stress, but we do not have an answer. But ICSI is definitely not an answer. That's the take-home message of this particular thing. Just a couple of more slides. In medical management, I think we all, antioxidants, whatever you want to give, but make sure there's CoQ10, lycopene, L-carnitine, zinc, and selenium. At least these things have to be there in your prep, and a max is 3 months is where you're putting them on antioxidants. How do you decide between clomiphene citrate, letrozole? I'm only mentioning these two because that's the commonest meds we all would want to write for our men. First of all, if your total serum testosterone done at 8 a.m. in the morning is in between 300 to 800 or 3 to 8 nanogram per mil or deciliter, then there is no role for hormonal management. Empirically, putting somebody on a clomiphene letrozole makes no sense at all. Using HCG or FSH therapy to a male partner, again, when your serum total testosterone is low, just to boost up the count will not help. That's point number one. If you really look at the evidence, if your testosterone is normal, there's no role for HRT, only antioxidants. And then if they don't improve, you'll have to move on and offer them IUI or IVF. In between clomiphene and letrozole, how do we decide? You'll have to look at the T by E ratio. So normally the testosterone by estradiol ratio should be 10. If it's less, it's letrozole, which is a aromatase inhibitor, or if it's more, you go with the centrally acting, which is clomiphene citrate. Clomiphene citrate, 25 milligrams once daily for 3 months. There's no cyclicity here. Letrozole, 2.5 milligram once daily for a max of 3 months. That's how we would decide between letrozole and clomiphene citrate here. HCG, unless the testosterone is low, we do not get on there. But if the testosterone is less, never give any form of testosterone. We still see sometimes men being given testosterone either as oral tablets, gels, or depots. A reproductive man who's not finished his reproductive needs should not be getting testosterone because it will cause suppression of the HPT axis, and we see iatrogenic azoospermia in this person. So do not give testosterone. So how do you improve testosterone? It's HCG. It's 5,000 units once a week or 1,500 or 2,500 units twice a week based on the BMI of the person. FSH, use of FSH has been in the literature in the present days, still no consensus, little controversial, let's not touch on that. No testosterone. The bottom line of today's discussion, no testosterone to a man who's not finished his reproductive needs. I've gone through that antioxidant thing. We're very happy to give a PDF of this PPT. Dr. Vijay Lakshmi can give you this PPT if you people really want it, because we are happy if you really want to go back and take this information and deal and manage the patients in your own OPDs. You do not have to refer the patient to a fertility center or a urologist. There's so much more that you people can do, and the first step is interpreting the semen analysis report. Surgical management, I'll not get deeper into that, but microtesy is possible. As Dr. Durga was saying, it's all about self-gamete conception. From a farmer in a village to probably a doctor or an IT professional in a city, nobody will come to us and say, you know what, I don't want my own gamete child. No, why don't I go for a donor gamete child? Nobody is saying this, whether it's India or the Western world. I think the first thing we all deserve to offer them is a self-gamete child. And this is where there's so much of improvement in surgical retrieval techniques, thanks to all the urologists for their skill acumen. And this is where your urologist is going to really do a magical role, and they need to be involved. There was a point where we said varicocele might not really be needed. We all said, oh, varicocele is crap, don't do it, it's not helping. But I think there's specific reasons, indications where varicocele could help. If it's grade 3, grade 4, there's persistent pain, or there's azoospermia, doing a varicocele repair might increase our retrieval of sperm. So I'll leave you with those thoughts. But please pick and select. Not everybody will benefit from a surgical intervention. A quick note on, it's not that we all are just talking without any evidence. So 2021, the European Association did come up with certain guidelines for practice. I'll quickly touch upon them. You have to take medical history and examination and do a semen analysis. That's the first point in the recommendation of the guideline, if you really see. When to do a hormonal evaluation, they've very clearly defined it. When it is less than 10 millions. Every man coming to you, you can't shoot them and ask them for reproductive hormones. I think there's an indication. When to get genetic evaluation. For every man, if the counts are less than 5 million or azoospermia, you get a karyotyping and Y chromosome deletion. Only if the VAS is not palpable, we're then getting the CFTR gene mutation screening. Sperm DNA fragmentation, it's not for everyone. It's only for people with RIF, RPL, and unexplained infertility. I'll take you a bit more detail into those. There's absolutely no role for anti-sperm antibody or a ROS testing at this point in time. A regular routine Doppler, just because we don't want to examine a male partner, sending them to a radiologist who could do a scan and tell us, is not required. Even if you're suspecting varicocele, they say examine. A surgeon's skill or yours as a doctor's skill, you can palpate varicocele. It is not an ultrasound finding. It is more of a clinical examination finding. When do you get a renal ultrasound? Only when you have a vas agenesis, because there's always a involvement of the renal system because they have a common embryological source. That's probably the indications and the guidelines. So that's probably an important slide to look at it. If your female reports are absolutely normal, just based on the semen parameters, if we had to decide how to choose between a timed intercourse, IO or IVF, that's probably the table. If your counts are absolutely normal, that's fine, go for a TI, but a count of 10 to 15 million with a motility of 30%, that's where probably we're looking at an IUI. An IVF, when it's in 5 and 10%, and anything less than 5 million, it's all going to be exceed. Just a little guidance. This is no recommendation from any scientific community, but that's how we plan and support. Again, every patient thinks, go to a fertility center, they end up doing an IVF. No, I think that's not the point that we all want to put it. Last slide, sperm DNA fragmentation. Again, this is a recent test, an advanced test, doesn't apply to everyone. If there's history of recurrent implantation failure, failed IVFs or multiple failed IUIs, recurrent pregnancy loss beyond 2 miscarriages, where it's idiopathic, where female side all your immunological workup has been negative. Think of the man having DNA fragmentation, because a severely fragmented DNA could bring about recurrent pregnancy loss, and it can be dealt with. Try antioxidants, it might come down or no, but I think there are newer ways of doing it, which is advanced sperm selection, which is microfluidics. For the last post-COVID 2 or 3 years, we've been using a lot of microfluidics, which is a chip-based technology, a very, very recent invention in the field of ART. It does help us separate the sperms with the best DNA. We've done the world's first RCT. Oasis has been, we take the pride in saying that we've done an RCT with the sperm DNA fragmentation as to which intervention would help. Because there are papers which said do teaser for these people, because picking it from the testis gives you the best DNA because it's not fragmented. Or do microfluidics, or simple, just do daily ejaculation. We always think some technology will make a difference. Need not be. Getting a man to ejaculate every alternate day could bring the DNA fragmentation. So we did a RCT with almost 300 patients, and the inference said that there was no difference in any of these interventions. All gave the best, which meant that always doing a surgical intervention of teaser might not be the best. Microfluidics gave us the best outcome, but however, daily ejaculation was helping us. So we sometimes do not want to think in a straight way. It's like, I can't forget my medicine professor scolding me in my 3rd year medicine posting. Somebody came with lymph nodes in the neck region, and I was thinking of Hodgkin's lymphoma, and I was beaten on my head. Said an Indian scenario, lymph node in neck. Why can't it be tuberculosis? So sometimes it's just looking at the semen analysis interpretation and thinking in a straight line than thinking, oh, this patient needs ICSI, this patient needs microfluidics. Do not complicate the situation. That's where I end my talk today. Take home message: history, examination, interpreting semen analysis. There's so much that you people can do, and that was just a glimpse. And sorry for shooting up the time there. Thank you, everyone.
Thank you, Chaitanya, for nice covering. Infertility is an individual problem. So each patient, when you comes to couple, so first you have to rule out the male factor. In the present scenario of sedentary lifestyle, due to the various jobs like the software and everything, so most of the cases are coming as a male infertility. So each individual is having different problems. We have to take the detailed history, detailed examination, then only go for the investigations. So we have covered entire topic nicely. So it is useful for the PGs and other the faculty. Thank you.
Now I request Dr. Venkatramana sir and Dr. Jayalakshmi ma'am to hand over a small token of thanks to Krish Chaitanya sir. Now I request Dr. Krishna Chaitanya sir to hand over a small token of thanks of appreciation from Oasis Fertility Center to Dr. Venkatramana sir. To Dr. Jayalakshmi ma'am. Thank you, sir. Now we move on to our third session. Now I request the chairpersons for the third session, Dr. Radha Lakshmi ma'am, Secretary of Foxy Kurnool and Professor of OBGY at Shantiram Medical College. Dr. Anita ma'am, Professor of OBGY at Vishwabharati Medical College, Kurnool. Now I request our chairpersons to introduce our third speaker, Dr. D. Vijay Lakshmi ma'am, Clinical Head, and ma'am is going to talk on challenging case scenarios in ART practice.
I know it's already late. I'll not take too much time. Like in any other fields of medicine, the management of infertility cases encounter a lot of uncertainties which create pitch darkness. It will be very challenging to find light in the dark. That is, to achieve successful outcomes despite all the odds. Today, I would like to present few of such challenging case scenarios which you might encounter in your day-to-day practice. So the first case scenario is, wife is a 32-year-old female. She's a software by profession. And husband is a 32-year-old male, software by profession. And he is an occasional smoker, occasional alcoholic. And he has the habit of keeping laptop over his lap. So her menstrual cycles are regular. married life of 4 years, and duration of infertility is 3 years. And coming to frequency of intercourse, it is 2 to 3 times per month. Just now, Krishna Chaitanya sir highlighted that it is like weekend intercourse. So only around the period of ovulation, and when I asked them both, due to work stress, we are unable to participate. In treatment history, she had multiple to 26%. Normal DFI is anything less than 15%. So here I want to stress the PGs the most, like you have to stress on the importance of history taking. At first visit, the patient did not give me any history. When I asked her, are you on any other drugs? But when she came for the next visit after the investigations to discuss, then I keep on repeatedly asking the same question. She did not open her mouth. The mother, beside sitting her, she told me she is on rabiprazole since post-COVID continuously. And previously, before starting IVF cycle also, her prolactin levels were raised, but she was given Capgolin 0.5 mg weekly for 4 weeks, and it came to normal level. And then we referred to an endocrinologist. There he stopped rabiprazole, and repeat prolactin after 1 month, came normal. So her BMI also got reduced from 34 to 29. Husband was advised few lifestyle modifications, and mainly not to keep laptop over his lap, and also avoid mobile phones in bedroom. So then we planned an IUI, and since there was previously 2 failed IUI, 1 failed IVF, and there was raised DFI also, we offered the couple of doing microfluidics in IUI. And when we are doing a follicular monitoring in IUI also, here you can see that on 10th day itself, on 10th day of menstrual cycle, the follicle is 20 millimeter, but the endometrial lining is only 7.3 mm. Just wait for the vascularity of the follicle to grow up. Don't be in a hurry to give a trigger, and see that the endometrium, because of endogenous estrogen, which the follicle is secreting, so by then the endometrium should build up with the endogenous estrogen level only. So on day 12, the follicle size was 24 millimeter. We had given only oral ovulagens. The vascularity was only 30 to 40%. So on day 13, it was 25.3 mm, and the vascularity was good, and even the endometrium was good. Then we triggered her. We gave HCG 10K. And then we had done microfluidics. What we are seeing, this device is a microfluidic device that we call it as lab on chip. It has a outlet. This is the outlet. This is a semi-permeable membrane. Sorry, this is the inlet. This is the semi-permeable membrane, and this is the outlet. And here you can see that here they are loading 850 microliters of seminal fluid into this inlet. Then later on, 50 microliters of Hippies media has been injected into this outlet, and remaining 700 microliters is being spread over the semi-permeable membrane. And then this microchip is kept in the incubator, dry incubator. So here what happens, it works on the natural principle. That is, the sperms, they travel themselves through micropores and channels, and then the sperms which are low DFI and morphologically normal, these sperms have been seen, and these sperms have been injected into the uterus. And then she conceived in the IUI, and she delivered a normal healthy baby. So what are the issues here? One is stress, because both are software. The other one is obesity. The patient herself has reduced weight and come to me. And other one is hyperprolactinemia and altered lifestyle habits. So stress, how does it affect? There will be increased cortisol levels, which will lead to reduced GnRH secretion and reduced estrogen and progesterone. So there will be anovulation, amenorrhea, decreased libido, and reduced implantation. Even in male also, the cortisol levels will be raised, same GnRH secretion will be low, and there will be hypogonadotropic hypogonadism, that is testosterone also will be low, and spermatogenesis also will be impaired. So obesity, chances of pregnancy is reduced by 5% for every BMI unit that exceeds 29 kg per meter square. So in obesity, what it happens, there will be more amount of free fatty acids which are accumulated in all the tissues, especially in the oocytes. They create more reactive oxygen species. So that will lead to follicular atresia, low maturity rate. And also there will be increased insulin, which will cause hyperinsulinemia and will lead to anovulation, hirsutism, and metabolic disorders. So in obese people, we require more amount of drugs, increased duration of stimulation, and along with altered gamete quality, we have also impaired endometrial receptivity. That is why, because there is increased accumulation of advanced glycation end products, which are the derivatives of fat and sugar molecules, which will detrimentally affect the developing embryo. In the same way, obesity, it also affects the male infertility. So there will be altered sperm function, increased DFI, decreased sperm mitochondrial activity, induced seminal oxidative stress. There will be impaired blastocyst development and increased miscarriage. So hyperprolactinemia, high prolactin levels will cause reduced GnRH secretion. That will lead to reduced FSH-LH, and there is impaired corpus luteal function, and hence the endometrium will be compromised, and there will be reduced implantation. So what are the possible causes of hyperprolactinemia? There are physiological causes also. We all know pregnancy, stress, exercise, lactation, even the act of coitus also. And immediately after getting from the sleep, immediately they should not give the sample, only after 2 to 3 hours. And pathological, that is hypothalamic pituitary tumors, and of course the drugs. So what does Endocrinological Society of Clinical Practice guidelines say regarding management of drug-induced hyperprolactinemia? There is no need to give dopamine agonist. We can stop the drug. But after stopping of the drug also, if there is persistent prolactin levels, then you have to differentiate between drug-induced hyperprolactinemia from pathological hyperprolactinemia, and then give dopamine agonist. So practical recommendations to modify the lifestyle factors. Just now Durga ma'am told age has very important role in infertility, and smoking, there is rapid depletion of oocytes and miscarriage rate will increase, and there is early resumption of menopause. Alcohol, caffeine intake should be limited to 200 milligram per day. Avoid anxiety and stress. And exercise, it will help us to release endorphins, which would help relaxation. Nutrition, we all know. And drugs, it is best to avoid all unnecessary medications and recreational drugs. And gadgets, especially avoid excessive irradiation by reducing contact with electronic gadgets. So the take-home points, we should not forget our basics of medical school practices. History taking should not be neglected. Even 5% of weight loss will help in improving fertility outcomes, and counsel regarding healthy lifestyle habits. Coming to case number 2, she's a 32-year-old female married to 33-year-old male. So the couple have one female child delivered by cesarean section, 7-year-old, and she is trying for second pregnancy since 5 years. On examination, the vitals and examination were normal. On perspeculum examination, the cervix was drawn up and it was not visible. Vagina was healthy. On pervaginal examination, only the small portion of posterior lip of cervix was felt, and uterus was mid position, fundus was not felt, and mobility was restricted. So, HSG was attempted in 2021, but it was abandoned as cervix was not visible. Husband parameters were normal. So we had advice for hysterolaparoscopy and planned for CPT, adhesiolisis, and bilateral round ligament plication followed by IUI. On laparoscopy, we can see here the uterus was densely adherent to the anterior abdominal wall and also throughout the bladder. This portion has been adherent to the abdominal wall and this portion was entirely adherent to the bladder. And we had done bilateral round ligament plication to make the uterus anteverted. So this what we are seeing, this is mid-post uterus, and in the next cycle, when we had offered for IUI, she told she had some function. So I had called her on day 14 of cycle just to see how is the endometrium, how is the follicle developing. Luckily, she conceived in the same cycle spontaneously without any of our efforts. And what I want to again stress is always do complete examination of the patient. None of our investigations can replace the basics. Case 3, 23-year-old, married life of 2 years. She has regular menses. On examination, everything is normal. Husband, he's a 33-year-old finance manager, non-smoker, non-alcoholic. He came to OPD through his semen analysis report suggestive of azoospermia, and BMI was 29. External genitalia examination was normal. On palpation, there was absent vas difference on both sides. There was no evidence of varicocele. Semen analysis, volume of 0.5 ml, pH was 7, fructose was absent. And when we had done semen analysis, we have not seen any sperms in the semen examination. So we centrifuged the sample and then did pellet examination. After pellet examination also, the sperms were not found. Then we had 2 results of azoospermia, before one and now one. So now we can tell him that he is azoospermic. On investigations, the hormonal analysis was normal. Even genetic testing was normal. And in USG scrotum, they told there is left side grade 1 varicocele. We had done, seeing the semen analysis picture, absent vas difference, we thought it to be a congenital bilateral of vas difference and did the transrectal ultrasound. So there was bilateral vas difference, and I had requested the radiologist personally to see for even the seminal vesicles and also the kidneys over the scan. So there was seminal vesicle absent or hypoplasia, and renal USG was normal. Then we subjected him for CFTR gene mutation that was found to be heterozygous gene mutation positive, and it was autosomal recessive. So female investigations were normal. Then we advised the patient also to get it done the CFTR gene testing, which also came negative. So we counseled the patient that it is an autosomal recessive inheritance pattern, congenital bilateral absence vas difference. When there is carrier parent and unaffected parent, 50% are unaffected children and 50% are carrier children. So the couple were not financially secured to opt for PGT testing. So they told anyhow the kids will be carrier, so we want to go ahead with IVF. So we had planned ICSI with TISA, and she had got 2 day 3 and 4 day 5 embryos, and she conceived in first frozen embryo transfer and she delivered a healthy male baby. So as Krishna Chaitanya sir told, male partner examination is also very important. So when we found bilateral absence of vas difference, then only we got a clue to get it done the other investigations. And before telling him that it was azoospermia, please always do semen analysis at least 2 times 4 weeks apart, before confirming them as azoospermic. And avoid testicular biopsy. And many couples tell us, first you see whether sperms are there or not in my husband's semen sample, then only we will do IVF. So if we want to do TISA also, then it should be done at a center where TISA sample freezing is available. And there is also a possibility of having their own biological child, even in cases of azoospermia, if proper evaluation is done. So case number 4, she's a 24-year-old female, married life of 1.5 years. She attained menarche at 12 years of age and gets menses only on withdrawal bleeding. So 2 cycles of ovulation induction and time intercourse was failed. First cycle, evidence of ovulation was documented with letrose and HMG. In second cycle, they had given only letrose. There was no growth of dominant follicle even on the 15th day. On examination, there were no signs of hyperandrogenemia. We were suspecting PCOD. And on scan, we saw antral follicle count was 30 and 22, and ovarian volume was 21 ml and 15 ml respectively. And when we investigated the husband, he was having oligoasthenoteratozoospermia. So when we investigated further, she had vitamin D deficiency. Her HbA1c was raised 6.6, AMH was 16.5, GTT was deranged, and were no signs of biological or clinical hyperandrogenemia. So treatment course at Oasis, IUI was planned in view of OATS. So in the first cycle, we gave her letrose 2.5 mg for BD for 7 days, and then HMG 75 for 3 doses. On day 15, the follicle was 20 millimeter, vascularity was 75%. We gave trigger. But on day 17, when I saw the follicle was 26 millimeter, not ovulated. So we gave her GCSF and triptorelin also. On day 18, when we saw her, the follicle has still grown up, and there was thick wall with echogenic fibrin-like strands, which was suggestive of LUF, which we see in our day-to-day routine practice. So in the next cycle, when she came on day 3, there was a hemorrhagic cyst, and we gave contraceptive pills. And in next cycle, when she came, we gave letrose 2.5 mg, and again HMG we repeated, but there was no dominant follicle on the 17th day. So patient was counseled for prolonged days of stimulation, chances of OHSS, and we gave her option of lap ovarian drilling or kappa IVM also. So this is the chart which is showing the international evidence-based guidelines, in which they say first line medical management, letrozole is the first drug of choice. Second line medical management with letrozole, if there is no conception or no evidence of ovulation, or there is follicular stalling, then we can go for gonadotropins or lap ovarian drilling. Lap ovarian drilling can be done where there is persistent high LH, when BMI is less than 25, or we are doing lab for any other cases, and we are giving gonadotropins, patient is unable to come for the follow-up. And third line of management is IVF. So patient lost weight of 2 kg and she did not turn up for 1 month. Then she was not willing for the surgery. Then she wanted to go ahead with kappa IVM. Then on day 2 scan, when we did, the follicles were 30 and 20. We gave menopur for 3 days, 150 mg, very minimal dose and minimal days of stimulation, only 3 days. And OPU was scheduled at 40 hours after the last dose of injection. So we had retrieved 19 oocytes, and 13 were mature, 12 were fertilized, and 6 day 3 embryos were frozen. So on frozen embryo transfer, when we transferred 3 day 3 embryos, and she is 5 months pregnant now. And first kappa IVM born baby in India at Oasis Fertility Warangal in Feb 2023. And first kappa IVM conception at Oasis Fertility Kurnool, Andhra Pradesh in September 2023. Such advanced technology is now available even at Kurnool. I thank Dr. Durga Rao madam for that. We are actually proud, the Rayalaseema people. So PCOS, why we have to classify them like PCOS phenotype A, B, C, D. So phenotype A and B will have this A, B, C all have hyperandrogenemia, and phenotype D is non-hyperandrogenic, and phenotype C is ovulatory. So phenotype A and B will have high risk of chronic diseases, and C and D have low risk of chronic diseases. And in phenotype C, Since she is ovulatory, she has lower risk of endometrial carcinoma. And phenotype D, since it is non-hyperandrogenic, they have least risk of metabolic syndrome. So I want to stress upon even the ultrasound and ultrasound significance in PCO, because when the patients come with the report, the radiologists say they don't give the antral follicle count and they just say PCO. Any patient, they label it as PCO, and the patient will be stressed. Even an adolescent girl or a married woman or a 45-year-old reproductive age woman, anyone will be stressed. So follicle number per ovary should be considered the most effective ultrasound marker to detect it as polycystic ovarian morphology. And follicle number per ovary should be more than 20 in at least one ovary in cases of high frequency bandwidth, or else ovarian volume more than 10 ml or follicular number per section, it should be more than 10 in at least one ovary if you are using older technology or image quality is insufficient or lower frequency bandwidth. So in vitro maturation, we have done kappa IVM for her. So this in vitro maturation is, we are maturing this germinal vesicle phase into metaphase 2 oocytes outside in vitro, that is outside. In the lab we are culturing. So normally in IVF routinely what we do, we give 10 to 12 days of injection. Then once the follicles reach around 18 to 20 millimeter, then we do a pickup after 36 hours, and then we remove the mature eggs, and then we do ICSI and we freeze the blastocyst. But in conventional IVM also, we give minimal days of injection, but we retrieve the follicles once they are at 10 to 12 millimeter of follicles. Here in kappa IVM, what we do is, here we retrieve the follicles at around 8 to 10 millimeters. That is, even the nuclear and cytoplasmic maturation of the ovarian follicle, it has been done outside the lab. So at oocyte retrieval, they are at GV stage. The nuclear and cytoplasmic maturation will take over. Once the follicles we retrieve, then we keep it in the kappa IVM media for 24 hours, where the nuclear and cytoplasmic maturation will progress. And then after that, we keep it in IVM media for 30 hours, where these germinal vesicles are converted into mature oocytes. So indications in whom it is indicated. Women with severe PCOS, now just we have seen this patient, and patient with malignancy who need immediate treatment. Resistant ovary syndrome, patients with thrombophilia, because we cannot give more days of gonadotropin injections, and hyperestrogenemia will cause hypercoagulability. And oocyte maturation problems, if in previous IVF cycle, if the patient has not got adequate blasts or low number of immature or no mature oocytes. So what are the advantages of this? Very few injections, no risk of OHSS, patient was very comfortable, and low cost. The success rate is around 40 to 45%. It can be started immediately at any time of the menstrual cycle, and the ability to harvest immature oocytes even from the ovarian biopsy specimens. So I think everyone will be interested with this luteinized unruptured follicle syndrome. There is no ovulation. The incidence being 25 to 43%, and recurrence rate is 78.6 to 90% in the consecutive 2 to 3 cycles. So what are the risk factors? Unexplained infertility, pelvic adhesions, endometriosis, PCOS, iatrogenic, NSAID, clomiphene, and hyperprolactinemia. We should avoid the patient, we should tell the patient to avoid NSAIDs at around the period of ovulation. So what are the types? There are two types, mature follicle and premature luteinization. That is, in mature follicle, there is already a follicle developed and the estrogen level will be 200 picogram, but progesterone will remain less than 2.5. In cases of premature luteinization, the follicle is not developed, it is not mature, but the progesterone level, there will be endometrium advancement. So the sonographic diagnosis, that is, there will be a thick follicular wall. When you see here, there is a thick follicular wall and echogenic fibrin strands. After 2 to 3 days when we do scan, there will be bright spots. and the PSV will be less than 10 centimeter per second, and the resistance index will be raising more than 0.5. And you can see even when we see the follicle on the this day and when we see on the next day, the follicle might have been enlarged to 3 to 4 centimeter. And persistent LUF at least on 2 consecutive TVS scans on different days after LH surge. So management of LUF. These are the take-home points for LUF. Do not give early or late trigger. Wait till the follicle is mature. There is adequate vascularity. Even the endometrium is optimum. Avoid clomiphene and NSAIDs. Clomiphene is to cause more LUF than letrozole or gonadotropins. Individualized treatment protocol, and better to give HCG 10K, or we can give, if we suspect LUF in this cycle, we can plan recombinant HCG in the next cycle, and dual trigger, that is HCG 5K and triptorelin 0.2 can be given. And in next cycle, if you want to plan, you can give GCSF 300 micrograms 24 to 48 hours prior to HCG. How did this GCSF will act? It will increase the neutrophil count and it will cause inflammation in the oocyte wall, and that will help in rupture of the follicular wall. So when there is persistent LUF, you can give OC pills, and if still it is persistent, better to go for IVF and counsel the patient accordingly. And this is the last case. She is a 39-year-old male, married life of 17 years, and husband is a 40-year-old male. And on exam, and previously he was diagnosed with azoospermia. On examination, bilateral testes are reduced in size with soft consistency. So cycles were regular. Frequency of coitus was 1 to 2 per month. She had 1 cycle of IUI, 1 cycle of IVF was failed. On surgical history, there was a lap ovarian drilling. It was done in 2012 and no reports were available. On examination, everything was normal except for posterior wall diffuse adenomyosis, and the AFC was low. It was 2 on right and 3 on left. On investigations, what we found significant was FSH was 14 and AMH was 0.9, which was suggesting poor ovarian reserve. And husband was not willing for further any investigations. He wanted donor sperms only. So, advancement of age, there is increased aneuploidy. Just now ma'am told there is increased aneuploidy as the age advances. And what we need to counsel, once we say the patient, your AMH is low, your egg reserve is low, your quality is been reducing, the patient will not understand. So when we show this slide and make them understand, like when the age is less than 35 years and there are 6 oocytes, the chances of forming blastocysts are 2, and the chances of having euploid blastocyst is 60%. That's why we get it even in IVF also, when we do for first transfer, the success rate is around 60 to 65%. In case of 39 to 40-year-old female, we need 11 oocytes. Why is it? Because they have more chances of aneuploidy. So 3 blasts, in that the euploid rate is only 30%. And in 42 to 43 years, when we have 18 oocytes, then chances of having blast formation will be 5, and the euploid rate is only 20%. So rest all eggs, either they get atretic, or it will be aneuploidy, or there will be blastocyst, embryo arrest. So in view of low reserve, we had counseled the patient like regarding poor quality of oocyte, chances of fertilization failure, embryo arrest, and success rate of 20 to 30%. They went ahead with their own oocytes, and we had done microdose floor protocol, and 2 day 5 blasts were formed. So when we had planned for frozen embryo transfer, when we were doing the HRT, we saw fluid in the endometrial cavity. Then we did an HSG. There was a corneal block on right side, and there was no evidence of hydrosalpinx. And even we have done to rule out the subtle infections, chronic endometritis in the uterine cavity, which is one of the causative factor for this fluid in endometrial cavity. We had done even CD138, that was also negative. So hysteroscopy we advised, and then we saw this dense adhesion. This is the right ostia, it is obscuring the right ostia, and there is a dense adhesion. Then we release that dense adhesion with the scissors. So post hysteroscopy, you can see this is fluid. This is before hysteroscopy. This is before embryo transfer. In the transfer cycle, when we saw, there was no fluid, and she conceived, and she is now 11 weeks, and she conceived with DCDA twins. And fluid in endometrial cavity, anyone can encounter even during the follicular scans also. So here what it happens, the embryonal apposition will not occur, or the embryos once formed, they might get even flushed off, resulting in implantation failure. The prevalence is 1 to 8%. And when we are measuring the endometrial thickness in the fluid in endometrial cavity, we should not measure the entire this thing. There are IATA guidelines. What they say is you should measure the anterior wall separately, posterior wall separately, and then add them both. So what are the causes and management? One, it can be menstrual blood. So when you see on day 2, day 3, and again when we call her on follicular phase, it might have been disappeared. And ma'am also told regarding niche isthmocele. If it is symptomatic, there is fluid accumulation or previous failed IVF, and there is fluid in the cavity, we can plan repair. And if it is associated with hydrosalpinx, plan lap salpingectomy. If there is subtle uterine infections, chronic endometritis, treat with antibiotics, doxycycline and metrogyl. If there are intrauterine adhesions, plan adhesiolysis. If there is cervical stenosis, can plan hysteroscopy and dilatation. So take-home message is here. In poor ovarian reserve, do not delay fertility treatment, and early referral to tertiary care center is preferred. Fluid in endometrial cavity, it should not be neglected. The underlying cause for the fluid in endometrial cavity, it can only be the main reason for the infertility. Just I want to show our Kurnool Oasis Center statistics in the last 1 year. Like when stalwarts like Durga ma'am and Krishna sir keep us guiding, the spectacular results come glaring. I thank you once again, ma'am and sir. And entirely this credit goes to the teamwork. We are really blessed to work in this hard-working and highly proficient team. Coming together is the beginning. Keeping together is the progress. Working together is success. I thank my Kurnool Oasis team for their continuous support. I thank one and all. Thank you.
So thank you, Vijaya. What is the cost of Kappa IVM? Kappa IVM.
Ma'am, it is 1.2 lakhs, ma'am.
Per cycle.
Yes, ma'am. And we
So
freeze the
is there
embryos.
any follow-up for the cases of which are done by Kappa IVM?
Ma'am?
Kappa IVM, because you are selecting the small follicles and you are doing IVF, and is there any follow-up? What is the follow-up?
Yes, ma'am, I'll tell you.
So because like a preterm baby, a premature egg is also not good for treatment.
Ma'am, till now we have done 40 primary cases, ma'am. Like in cases of PCO, where the AMH was more than 5 and the follicles were at least 15 on each side. These are primary indications. And in 20, we have done previous failed IVF cycles, where there were like, we were not getting any mature oocytes, we did not get good quality blasts and all. So among them, among 40, 4 they did not have any eggs, any oocytes, 4 they did not have any embryos. And in 32 cycles, 22 frozen embryo transfer has been done, and the clinical pregnancy rate is 41%, ma'am.
Thank you.
Madam, your question was about the future in terms of
future.
Okay. So frankly, Kappa IVM, this we have only come into collaboration with Brussels University. In India, we are the only ones that we have an association with. Kappa IVM, quite a lot has been done in Vietnam and in Brussels. So right now, Kappa IVM in terms of the children born, it's only been between 2 to 4 years. But IVM has been there, and there's a lot of data to say about the safety of IVM. Kappa IVM is something which is very, very new. It's only been in the last 2 to 3 years that it has been there. But IVM as such, there are studies which have looked at the children, the neurodevelopmental thing, and that is safe. As safe as IVF.
One more question for you, Madam, Durga Madam. So what is your opinion about social egg banking? So because nowadays most of the people marrying after 30 years, especially software, even the medical profession. What is your opinion, madam?
So I think again here the awareness is something that we have to initiate and improve. Now, though a lot is going on in the media, and we are tending to see a lot of women who are coming to bank, what is very important is to let them know that banking should happen before they turn 32, 33, as early as possible. If they come at 37, 38 saying that, like, now I don't know when I'll get married, let me freeze then. Yes, we will still freeze even at that point, but their chances of pregnancy is obviously higher should they freeze it when they are much younger. And very important for people who have, like I was talking about, endometriosis. Now that's a progressive disease. And even though we do tell them to be on the pill or dynagist or anything like that, they might stop. And then it gets progressive. By the time they come back to you, they'll have bilateral cyst, huge cyst. We'll have to do cystectomy, reduce their ovarian reserve. So in these group of people also, it's very important that we talk about oocyte vitrification. But again, a lot needs to happen in terms of awareness for the women as well.
Thank you, madam. And one more question for Krishna Chaitanya, sir.
I think he just left, but I'll try and answer that for you.
Okay. So what is your opinion about CASA, madam?
CASA is definitely a very useful tool. The only drawback to CASA is it takes the embryologist to just give a simple sperm analysis, because again they have to sit and do the reading. Even though that the time of an embryologist is very important, and that takes them somewhere between 1 to 2 hours to just do a simple sperm analysis. So yes, it's very good. It gives you even the DF and everything else, but it's very labor intensive. That's the only drawback about CASA.
Vijaya, very beautiful presentation. I think it was a great learning experience for us going through the case-based scenarios. I have one question for you. When you practice in the cities, it is different. And in the Kurnool town, what is the age group you encounter for infertility? And what is the main cause? Both male and female factor infertility.
Here we see right from 19-year-old female to 46-year-old female we see. And more cases what we see is they don't have the knowledge of like these fertility treatments are available, and they're unable to come to the fertility center. By the time they come here, their married life duration will be at least more than 10 years. I see all cases like more than 14 years, 16 years. These sort of cases I'm seeing more. And in younger generation nowadays, what I'm seeing is there are poor quality of, there are more chances of raised cases of unexplained infertility and poor quality embryos. When we are doing IVF even for 21-year-old female, because by the time she came to me, she would have done 6 to 10 cycles of OITI, some 3 to 4 cycles of IUI. When we subject for IVF, what I have seen is there are very poor quality and poor chances of blast formation. And
So irrespective of the age you are finding.
Irrespective of the age.
So does ovulation, repeated ovulation, induction reduce the quality of the embryos?
No, ma'am, I don't.
That is not related. And what is the cause of, like it always bothers me, we say lifestyle, environment, pollution and all that, the food habits, but what is the main cause of increased incidence of PCOS?
That is again lifestyle modifications only, ma'am. I believe lifestyle modification only, because no one will sleep before 12, and all are like nowadays, if it is weekend, go out and eat. We are seeing that culture. Even the kids, even 2 to 3-year-old kids, they don't sleep till 12.
Yes, we experience the same thing with our kids also.
Yeah.
So
And there's a lot of incidents and association with genetic preponderance of PCO. In fact, there is something called as Bartter syndrome. You have a mother who's got PCO, she conceives, she delivers a child. If it's a girl child, that child is more likely to be PCO. So this kind of genetic predisposition is also very, very high when we are talking about that.
ma'am,
Which is
whatever
why-
said and done, if we say you don't eat junk food and all, or you have to do like it's not like it's not the kind of thing which can be practiced.
Correct.
So,
But then
like,
again, it's only a question of awareness and constant education. And nowadays, in fact, you're tending to have a lot of anti-obesity drugs, which are making a great difference in terms of weight loss. So whether, we catch them early, give them the right kind of advice, put them on these medications, you have, liraglutide and all of these medications which are having a great impact in terms of weight loss. So I think slowly things are improving in terms of what we can also do pharmacologically to help them, give them that additional push towards weight loss.
Thank you, ma'am. Thank you. I take this opportunity to congratulate the Oasis team. Durga ma'am and Krishna Chaitanya sir's lecture was like, I just felt I was sitting in a classroom. Very beautiful. Vijaya, congratulations to you also.
So congratulations, Vijaya, and thank you very much, Durga Madam and Krishna Chaitanya sir. A small announcement on behalf of Foxy, Kurnool. So thank you very much for giving me the opportunity. So 17th of March, there will be a CME, which has been postponed on 30th of December. That will be conducted on 17th of March. So it is sponsored by Sun Pharma people. So anyone who want to give a lecture on that day, please contact me personally. And on 23rd in Nanjal, there will be a CME sponsored by GSK people. So I am happy to announce that our society is number 3 in AP after Vizag and Vijayawada. So Vizag is 400. Vijayawada is 340, ours is in 3rd position with 330 people. So we came from 120 to 330. Give a big round of applause. So one more announcement is we got permission from Central Foxy to conduct one ICOG CME. So with 5 ICOG credit points. So we are applying for 2 APMC credit points also. That will be conducted after July. So anyone whoever not got certificates of OBG gynec practice, that is with 2 APMC credit points, please contact me either by message or phone. So thank you very much. Thank you one and all.
Thank you, ma'am. Now I request Dr. Durgaji Rao, ma'am, to hand over a small vote of thanks and appreciation on behalf of Oasis Fertility Center to Dr. Radha Lakshmi, ma'am. To Dr. Anita, ma'am. I would like to thank each one of the doctors present here for taking time out to attend the CME today. And I would like to thank Dr. Durgaji Rao ma'am, Dr. Krishna Chaitanya sir, and Dr. Vijay Lakshmi madam for such an excellent, interesting, enlightening presentation. And I would also like to thank the entire team of Oasis Fertility, starting from the marketing, BD team, and operation team, who have been working relentlessly to put this program together. Thank you very much, one and all, and we can head over to lunch now. Thank you.
There is live band music also. You can enjoy your lunch along with the music. Thank you. Have a pleasant Sunday.